Thank you for the lovely introduction. I would like to begin by acknowledging the Dark and Young people who are the traditional custodians of the lands on which I work. It always was and always will be Aboriginal land. So, as mentioned, I'm going to be talking about a bit of a long journey we've been on the Central Coast to improve dementia and palliative care. So where did it all begin? Well, back in 2019, the Central Coast Local Health District was awarded a MRFF Rapid Applied Research Translation grant through the New South Wales Regional Health Partners. So this grant had two aims to it. Part of it was about promoting research and research capacity amongst our palliative care clinicians. And then the other part of the grant was about actually improving palliative care and end-of-life care for our Central Coast community. So when that funding arrived, there was a sort of long process of sort of stakeholder workshops. I think there were 5 in total throughout 2020 to sort of identify what are the priority areas for palliative and end-of-life care on the Central Coast. And one of the topics that were raised by stakeholders was dementia. So from that, 2 projects were identified. The first project is a rapid review that we did looking at existing models of care to support people with dementia at the end of life. This project was led by Professor Nick Goodwin and Dr. Suzanne Lewis. The other project was around improving the end-of-life care journey for people with dementia and their carers, and this was led by Dr. Sally Carr and Danielle Davis. We're very proud that we've actually published 3 papers from these 2 projects. They're all open access, so if anything I talk about today sparks any interest, you can go online and find those publications or come and see me and I can give you more information about those. So I'll give you a bit of insight into the rapid review that we did. So we wanted to know what models already exist for people with dementia who are approaching the end of life. We identified through our review 12 models, and one of those models you've already heard about today. The Nightingale program was one of the models we identified in our review. So when we looked at the existing models, a number were Australian-based models, but a lot of international models as well. What we found was there was quite a lot of variability between these existing models. So some of them covered different settings, some were residential aged care facilities, some were based more in hospitals. There was quite a bit of variation around the scope of these models. So some provided education, referrals, and there was quite a degree of integration around the duration of care, so how long these models existed for, the number of weeks, what locations they covered. And one thing we found though was that most of these models had a care coordination role as part of them, which we've heard a lot about already today. One thing we found from this review was that these were mostly feasibility studies, so we didn't really know much about what's the sustainability of these models once they're implemented, and more broadly, the impact that they're having. Yeah, so like I mentioned, published open access in palliative medicine if you want to read more about those models. After that, we did a retrospective clinical audit. We looked at patients who had died with dementia on the Central Coast, and we compared the experiences of people who died within the hospital to other settings. What we found from the results of that audit was that the characteristics of people differed by that place of death. So we found that people dying in hospital were more likely to be living at home, either with family or alone, and to not have a spouse. We found that less than 1 in 5 people had advanced care documentation. We also found that many people were still being actively treated at the time of death. So we found that almost 1 in 2 people who died in hospital had some sort of investigation in their last 72 hours. We found that less than half of people were coded as receiving palliative care at the time of death. and more than 2 in 3 people did not get access to specialist palliative care. We were interested to look at some of these measures of function to see if there was an association between those and the terminal phase. So we looked at albumin, falls risk score, and the Waterloo score. And we worked with some amazing statisticians at the Hunter Medical Research Institute who found that there was indeed an association for these people who died with dementia between those 3 scores and that declining function within 14 days of death. We then went on to do a mixed methods research study. So this involved 2 different participant cohorts. We spoke with bereaved carers who had cared for someone with dementia at the end of life, and we spoke with healthcare professionals. And we did a lot. We surveyed them, we interviewed them, and we ran workshops as well. So with all of that data, what we did is we triangulated all of that and we identified 5 really key areas where we need to improve palliative care for people with dementia. And a lot of these things we've already spoken about today. So it's about timely recognition of end of life. It's about being able to have conversations about palliative care and end of life. It's about providing support and information to people with dementia and their carers. It's about putting the person and their carer at the centre of care. And it's about having quality coordinated care. So this is what we need to improve on the Central Coast. So from that, at the end of 2022, we'd finished this research, we'd identified all these issues, and we were like, okay, what's next? We formed a relationship with Hammond Care because they came to us and said, we're also grappling with these issues around dementia and palliative care and how we can improve things. And we said, okay, well, should we go on a journey together to try and improve dementia and palliative care? So we agreed to undertake a co-design process. And this process was really informed by the work of K.A. McKercher, who does a lot of incredible work in the co-design space. And there's 4 principles that they articulate around co-design. And they are around sharing power, prioritising relationships, using participatory means, and building capacity. So these were the principles that were really underlying the journey we're about to go on together. We were very lucky to get a small amount of funding from the HMRI Healthcare Transformation Research Program. They gave us a seed grant, which allowed us to put on some catering, which always helps to get people along to co-design workshops. So I have this slide here, mainly thanks to one of my incredible colleagues from the PHN, who's actually doing a PhD in this area. So I have to make a note around the different co-approaches. You've probably heard the word co-design before, maybe the word co-creation, co-production, and often these words are used interchangeably. We decided we would describe our journey as co-design. And there's a really good paper I've included on the slide there if you're interested in some of the differences between the different co-approaches. So this is what we did throughout 2023. We ran 7 workshops. And we started off by coming together and talking about what is the need that we're trying to address. Then we, as a group, talked about what's our mission and purpose going to be, what are our top priorities, and then we set about building a logic model. We did some work to refine that, and then we got some external feedback, and I'll talk about that in a bit. So the first workshop was really about all of us sort of coming together and getting to know one another, and that, I guess, refers back to that previous point around the importance of relationships. And we talked about whether or not we needed to develop a new model of care, and the answer very much from everyone in the room was yes, we need to do something. this was the mission and purpose we came up with together as a group. So we said our mission was to improve care experiences and outcomes for people and carers living with dementia at end of life. And we wanted to work collaboratively to establish a value case for an improved model of care to enable funding for a pilot project. There were a lot of issues that came up throughout these workshops. We had a really diverse group of stakeholders, which I'll talk about in a moment, but we were all very good at identifying a whole range of issues, and we thought, okay, well, we can't tackle all of these at once. What are our top priorities to address? So we decided as a group the top priorities were to improve education on dementia and palliative care, to improve care coordination, and to ensure there's better communication. And again, we've spoken a lot about these already today. So as a group, we ended up having sort of over 100 people engaged throughout this process. But as you can see, not everyone came along to every workshop, but there was a lot of interest, not just on the Central Coast, but more broadly around improving dementia and palliative care. So we had managers, researchers, clinicians, aged care providers, and that's just to name a few. It was a very diverse group. And we also had some consumer and carer representatives as part of that process as well. And I've got a lovely quote here from Dr. Sally Carr, who's our Director of Palliative Care, who's reflecting on how, I guess, beneficial it can be to have these co-design opportunities. How often as a clinician you can get so focused in on your perspective and you can forget the broader picture. So I think that's a really beautiful description of the benefits of working in this way. I'll just go back and say that question, whose voices are missing, we tried to remember to sort of ask that at the end of every workshop. We would try and reflect on, okay, we've had this great conversation today, but who's not part of this conversation that needs to be? Who can we invite along to the next workshop? So this is what we came up with. This is the program logic model. So it was obviously informed by that rapid review I spoke about and all the existing models of care. But then we had to make it, I guess, bespoke to the Central Coast in our local context. So it's probably a bit hard to see on that slide there all of the detail, but happy to share a copy of that with anyone who's interested. So we came up with that logic model and we thought, okay, let's try and get some feedback, because we'd been working as a group and kind of had refined the model, but we thought, okay, there's other sort of brains we need to tap into. So we had the opportunity to go along to the Asia Pacific Conference for Integrated Care, which was in Sydney late last year, and we held a workshop, and we had amazing people come along to the workshop from all different backgrounds, and they looked at our logic model and they weren't shy in giving us feedback and telling us where we needed to improve, which was really helpful. So they gave us advice around further clarifying what the eligibility criteria were, the referral pathways, and there's been some amazing examples today about, those eligibility criteria and referral pathways and how clear they were. So very inspired by other presentations. And as well, that third point around, terminology and advanced dementia, or as we heard this morning, advancing dementia. We got feedback that we needed greater consideration of how the model would meet the needs of First Nations peoples. And we also needed to do some work around how would our model fit within the broader sort of services that already exist. We took a moment as a group to sort of evaluate our efforts. We thought, okay, we've been doing all these co-design workshops. What's sort of been the impact of that? So we did a survey of some of our stakeholders who'd been coming along and asked if people felt like they were being heard. And most people said they were, so that was very reassuring to see that people felt like they had a voice. Because as you can imagine, it can be quite tricky, the different power dynamics, and that's sort of one of the principles of co-design kind of informing this work is around how do you sort of share that power in a room. So it was important that we saw that people did feel like they were heard. And most people were satisfied with the model that we'd come up with. There were some other really nice outcomes from the process. So having these workshops where all these different people came together, people said it was a networking opportunity. So that was nice for people to meet other people working in the dementia and palliative care space. And as well, a number of people said they actually had increased awareness of services that exist. So given that the top priority as a group was improving education, the fact that even throughout the co-design process, people were growing their awareness of services, that was really nice to see. And there's some nice quotes there from people saying that, it was, I think in particular that last quote, I think it was reassuring for people who are really passionate about dementia and palliative care to be like, there's all these other people who also really care about this issue. So I think that was helpful for people. Where are we up to now? Well, good things take time. We are really sort of pleased that as a result of the research that we did, we were sort of able to advocate for a new dementia care coordination service, which is currently in development. And I should also plug, I've got 30 seconds, so I'll be quick. I'll plug quickly as well, because we've spoken a bit about care coordination today. Just yesterday, we launched a new professional certificate in care coordination, which has been developed by clinicians at the local health district and the University of Newcastle. So that course has been developed for healthcare professionals. So if anyone's interested in that training, come and see me. I'll chat to you. But yeah, our next steps are to think about education. We need more engagement with primary care. And lastly, but not least, we need that elusive funding to try and implement and evaluate our model. So nice quote there from our last workshop. We've got a long way to go, but we've made some good progress. This slide just mentions just a couple of the many, many amazing people who have been involved, some of who are in the room today who have contributed to these workshops. So thank you to everyone for their contribution to this work.